My sincere greetings to the listeners. I am Chidambaram Ramasamy, one of the third year medical residents from St. Vincent Hospital, Worcester. I am grateful to talk about a case of diffuse cystic lung disease. Diffuse cystic lung diseases are a diverse spectrum of diseases with various etiologies. The commonly reported diffuse cystic lung diseases includes lymphangioliomyomatosis, pulmonary Langerhans cell histiocytosis, lymphoid interstitial pneumonia, Bird-Hogg-Dubé syndrome. The clinical presentation varies from incidentally detected lung cysts in their routine imaging to life-threatening pneumothorax. With a better visualization of lung cyst by high-resolution computer tomography, the approach to diffuse cystic lung diseases has changed drastically. It enables us to narrow down the differential and in some cases providing a definitive diagnosis, thereby avoiding invasive lung biopsies and their complications. Here, we described a case of diffuse cystic lung disease with spontaneous pneumothorax and our approach to the diagnosis. 49-year-old Asian female presented to our pulmonology clinic for evaluation of incidentally detected bilateral lung cyst with spontaneous pneumothorax. She is a lifetime non-smoker. She immigrated from India 20 years ago. She never had tuberculosis. She was not able to recall any lung diseases in her family. She was asymptomatic during the visit and saturating 98% on room air. Her physical examination was unremarkable. As you can see here, her imaging with high resolution computer tomography showed mid-lung to basal predominant bilateral pulmonary cysts. Her pulmonary function tests were within normal limits. Further evaluation showed normal levels of serum vasculoendothelial growth factor and alpha 1 antitrypsin levels. Her autoimmune workup, which was done for lymphoid interstitial pneumonia, was also negative. Her imaging is negative for renal cysts. Given the negative history of tobacco exposure with a normal serum levels of vasculoendothelial growth factor and mid-lung to basal predominant lung cysts in her imaging, narrowed her differentials to Bird-Hogg-Dubé syndrome, which was then confirmed with a genetic analysis of folliculin gene mutation. Bird-Hogg-Dubé syndrome is a rare autosomal dominant condition with varied clinical manifestations, including pulmonary cyst that predisposes them to spontaneous pneumothorax, benign skin lesions on head and neck, and early onset renal cell carcinoma. It is caused by a germline mutation of folliculin gene in chromosome 17. Characteristic basal to mid-lung predominant lung cysts in the Bird-Hogg-Dubé syndrome differentiates this syndrome from upper lobe predominant cysts in pulmonary Langerhans cell histiocytosis and diffuse and bilateral cysts in lymphangioliomyomatosis. Bird-Hogg-Dubé syndrome without the skin involvement, like in our case, was also reported in our literature. Asymptomatic pneumothorax is managed conservatively. Pleurodesis is recommended for recurrent pneumothorax. These patients are advised to avoid scuba diving, air travel to prevent rupture of cysts. Early diagnosis is crucial to initiate lifelong imaging surveillance for renal cancers, which determines the disease prognosis. Proper genetic counseling and screening of asymptomatic family members are also essential. Thanks for listening. Thanks for your time and attention.